Next up is Kathir Subramanian, Professor and Chief of Cardiothoracic Anesthesia at UPMC. Kathir has been an outstanding clinical and operational partner with the HVI in a variety of projects. Thank you, Kathir.
Thank you, IPS and HVI team for inviting cardiac anesthesia here. Well, life of cardiac anesthesia was so predictable. It is general endotracheal anesthesia, muscle paralysis, transport the patient to ICU at the end of the case, it's over. But it has changed so much nowadays after invention of these transcatheter procedures. Look at the list. You can give local anesthesia only. You can give local anesthesia with mild sedation, which is called conscious sedation. The local anesthesia with deep sedation, which is basically a general anesthesia without endotracheal tube. So the difference is you can stimulate the patient, wake them up in mild sedation, but you can stimulate, but patient won't wake up in deep sedation. So you can do general anesthesia with endotracheal tube or with laryngeal mask airway. You can do general anesthesia with positive pressure ventilation, also spontaneous ventilation. So this is the recent 2023 paper, comparison of safety and effectiveness of local or general anesthesia for TAVI. So this study included 34 studies. Published between 2002 and 2012, more than 20,000 patients included in the analysis. You can see the procedure time, fluoroscopic time, and length of stay all favors local anesthesia with conscious sedation. So the use of cardiovascular drugs like inotropes, vasopressors, all decreases with the use of local anesthesia and conscious sedation intraoperatively. The incidence of major bleeding also favors local anesthesia with conscious sedation. The acute kidney injury, I do not know how to explain this. It favors general anesthesia. If you have lower hypotension, if you have lower use of cardiovascular drugs, why the acute kidney injury is more in local anesthesia? It is something to be tested and investigated further. There is no difference between general anesthesia and local anesthesia in 30-day mortality, procedural success, shock, myocardial infarction, cerebrovascular accident, pacemaker rate, or perivalve leak. So there is some bias in comparison of anesthesia techniques. The general anesthesia is advocated initially during the early part of learning curve, and general anesthesia procedures done in difficult patients, general anesthesia procedures done for complex procedures and complex approaches. So how do you eliminate this bias? So one randomized clinical trial was published between general anesthesia and local anesthesia, SOLVE TAVI trial, 447 patients. The primary outcome was 30-day composite morbidity and mortality. So what they found is there is equivalence between general anesthesia and local anesthesia in terms of primary endpoints. So you take the less invasive option, which is the local anesthesia with conscious sedation. There is lower requirement for inotropes and vasopressors in local anesthesia group. So the proponents of general anesthesia will say the patient is immobile, patient respiratory motion is controlled. It is ideal for an interventional procedure. Airway is protected. Respiratory depression is avoided. You can use TEE whenever you want under general anesthesia. If a procedural complication happens, it is easier to manage under general anesthesia. However, local anesthesia proponents will say that hemodynamic disturbances, mechanical ventilation significantly increase perioperative risk. Longer recovery, longer hospitalization increase the risk of infection before discharge. If you have a general anesthesia with delayed recovery, neurodysfunction is delayed detection and delaying treatment. So general anesthesia is unavoidable if the patient is failing to maintain proper position, like Parkinson's disease or neurologic disorders. You are not able to lie flat in a bed, in an interventional table. Patients with severe back pain, failed back syndrome, patients with severe orthopnea, constantly coughing. We encounter this patient quite often. Patients with morbid obesity, more than 35 BMI. Or the patient that doesn't want local anesthesia, patient wants general anesthesia. And then surgical approaches, transaxillary, transaortic, or transapical requires general anesthesia. Peri-procedural conversion from local to general anesthesia is not ideal. This is a registry from Germany and Stanford. The conversion rate reported was 3.3%. Procedural complication, respiratory distress, cardiovascular decompensation, and the patient is restless on the table. So those are all the common reasons for the conversion. They compared the converted patient versus non-converted patients. You can see the 11% 30-day safety in non-converted patient compared to 37 patient had some complication at 30 days. So the conversion of local anesthesia to general anesthesia is not ideal during the procedure at all. So you want to predict which patient will tolerate general anesthesia, will tolerate local anesthesia with conscious sedation carefully and plan it accordingly. So these are all the patients where there is a possibility of hemodynamic instability during the procedure, impaired LV systolic function, impaired diastolic function, grade 3. If you have a patient with collateral dependent coronary circulation, untreated coronary artery disease, pulmonary hypertension, right heart dysfunction, significant other valve disease, patients with significant other system disorders like pulmonary disease or renal disease or frailty. So these patients, you can predict these patients are going to behave differently, so act accordingly in the intraoperative period. Preoperative optimization in the preoperative clinic has a significant role. Anemia increases the transfusion. Anemia by itself an independent predictor. Transfusion itself is an independent predictor of bad outcomes. So avoid these two combined together. Nutritional status can be improved as much as possible. Frailty assessment is a part of TAVR workup. Pulmonary disease is very common in patients undergoing TAVI and other invasive procedures. Optimization of pulmonary disease goes a long way to avoid complications. Vulnerability to postoperative neurodysfunction like aortic disease, carotid disease, previous stroke, previous TIA has to be worked up before the patient comes to the operating room. So other transcatheter procedures other than TAVI. So there are several procedures we do only under local anesthesia nowadays, like atrial septal device closure with a minimum sedation. Except some patients will require general anesthesia and TEE. As we are talking about these Watchman procedures in future, maybe when the ice picks up, we may do those cases also with sedation, now general anesthesia. Rest of the procedures in the list, like mitral clip, TriClip, transcatheter mitral valve replacement, all these procedures are nowadays done under general anesthesia, endotracheal tube, muscle paralysis, invasive monitoring, TEE. But there are several centers who do it under sedation also. But majority of the centers do under general anesthesia. So to conclude, the principles of anesthesia management, preoperative optimization is important. Selection of anesthetic technique tailored to the procedure and the patient. Early detection of complications intraoperatively and postoperative by anesthesia and perioperative team is very important. Common theme, the type of anesthesia or anesthesia technique or type of medication administered is less important than the manner in which the anesthesia is conducted or a drug is administered. So type A versus type B doesn't make a lot of difference. Drug A versus drug B doesn't make a lot of difference, but the way you administer type A technique or drug A techniques is very important. Most anesthetic technique reduce sympathetic tone, leading to vasodilation, reduction in systemic pressure. Thus, anesthetic management must ensure the proper maintenance of organ perfusion pressure. Thank you very much.